So, Maharashtra University students had their exams just 2 days back, had their surgery paper too. And one very interesting question was asked to them. It seemed very simple, but I just want to break it down and teach you how to really approach this question. Because, be it UG, be it PG, when you are giving your university exams, we as examiners, we are expecting some things that has to be there in your answer, even if it is as simple as the question is as simple as of inguinal hernia. So let us just start with the question. Before that, I am Dr. Nihar Thakkar. I'm a general surgeon and a passionate educator myself. Welcome to my channel of Logical Surgeon. So without wasting any time, let's begin. The question that was asked was that 75-year-old patient with diabetes since 15 years came to the surgery OPD with swelling in the right inguinal regions in 6 months. What is the differential diagnosis? How will you investigate and describe various surgeries? So let us break it down. Let us take one question at a time and decide for it how to answer the question and learn the approach. So the three important things that they have given here is that 75-year-old patient. So no, they have not mentioned any gender here. So there is patient, DM since 15 years and swelling in right inguinal region. The first question they have asked here is what are the differential diagnosis of inguinal swelling? See, now consider whenever such a question is asked regarding differential diagnosis, you need to keep the most common pathologies first, okay, and then go to the rare diagnosis. So I always say that you always keep your donkeys first and you end with your zebras. Also, whenever you are dealing with a question where a swelling is there, maybe in the abdominal, in one of the abdominal quadrant or in the inguinal region, you need to think of all the possible organs which are present just below that, in that quadrant, or in maybe in this question in the inguinal region. So what do we have in this inguinal region? We have the inguinal canal, that cannot be missed. Other than that, you have the cord. Then in the cord we have the veins as well. Then you also have inguinal lymph nodes. You have femoral artery, right? And if you see inguinal region, groin region is the inguinal region, as well as just below the inguinal, so femoral region, femoral canal. Okay, so you have all this. I'm giving you hints. So you have all these areas, okay, all these structures in the inguinal region, just below the inguinal region. So whenever you are thinking about the differential diagnosis, you start from the donkeys, go to the zebras. The first differential has to be a inguinal hernia. Whenever you are writing the differential diagnosis, also make sure that you are also writing how will this swelling present to you. So we know that the inguinal hernia swelling, uncomplicated, will be reducible. Okay, the swelling will be soft in consistency. Okay, and cuff impulse will be present. Okay, then next is of course you have the femoral hernia. And femoral hernia, how you differentiate it from inguinal hernia? Femoral hernia will be the swelling will be below the inguinal ligament. Okay, below the inguinal ligament there will be the swelling. Okay, if it is uncomplicated, it will be reducible, and again the cuff impulse will be present. Okay, but also you will say, sir, this is more common in females. Yes, you are right. So here they have not mentioned the gender, so it is just patient. So you will have to keep this differential in your mind. And we know that many of your femoral hernias, this directly present to you with complication. Okay, so uncomplicated femoral hernia, though rare, but it can be present. So another differential would be, as we discussed, that inguinal hernia, inguinal canal has a cord, the spermatic cord, and in this cord we have the pampiniform plexus. So in pampiniform plexus we can have varicocele. Okay, in pampiniform plexus we can have varicocele. So varicocele is another differential diagnosis. How will you differentiate? It is again reducible. Okay, it is not compressible, it is reducible. So when you reduce it, it will go in and it will not come out till the time there is an external force which is applied. If this would have been a compressible swelling, it would appear as soon as you release the force, right? But this is reducible. And the varicocele, what is the hallmark of varicocele? We know that we get bag of worm appearance, bag of worms in the scrotum. So yes, that is another thing. Then what else could it be there? There is a cord, and this cord can have a lipoma. So there can be the another differential is cord lipoma. Then you have inguinal lymph node. Say the patient has lower limb swelling, and this could be due to some infection, say Madura foot or something else, but it is not given in the question. You can take the liberty to assume that this patient will have. So this Madura foot or maybe some cellulitis can give you inguinal lymph adenopathy. So that is another differential here. The inguinal lymph node will be firm, it will be tender, right? The swelling will be tender. There can be some local rise of temperature if it is infected. So you need to take that into account as well, right? Another differential is psoas abscess. Psoas abscess, though it is rare, but it can be secondary to pot spine. So pot spine, say the pus trickles down, it becomes psoas abscess and can come out as a inguinal swelling. So again, there will be fever associated, there will be spinal tenderness in this patient, and this, if you see this swelling would be soft to firm, fluctuation will be present because it is a abscess, right? So you will have to keep this in mind as well. Then a rare diagnosis would be femoral artery aneurysm. So femoral artery aneurysm, it won't be, the swelling per se won't be reducible, but it will be compressible. So compressible swelling and pulsatile. Okay, this is another hallmark which will tell you that this patient might have femoral artery aneurysm. And there is one more thing. Okay, there's one personal experience that I would like to share with you. There was a young male who had come to us, and he presented with inguinal swelling, and it was firm, it was soft. Okay, there was regular, there was local rise of temperature, there was tenderness. So we were thinking that it could be infective. So to confirm, we did a USG confirmed that it was inguinal abscess, but we couldn't find out the cause. So before actually doing an IND, we thought that we would go and do a CT to find out what was the cause of this abscess. So what came out, okay, really was surprising, because we found on CT abdo-pelvis, we did IV with oral contrast. We came to know that this patient had sigmoid diverticulitis. Sigmoid diverticular disease was there, which was inflamed, and that inflammation had ruptured, and it was causing pus in the pelvis. So there was a pelvic abscess, a Hinch's classification 2, and this pelvic abscess came down in the inguinal region and it presented as an abscess. So this was a rare diagnosis, but it was there. So inguinal abscess, secondary to pelvic abscess, secondary to diverticulitis, sigmoid diverticulitis. There's another differential that you can have. Next, going to Saphenous. Though it is rare, we know that because of the dilated SFJ, secondary to the varicose, in incompetent SFJ, you can have saphenous. So this is another differential. The other question that came was, how will you investigate this patient? They have asked you specifically, how will you investigate this patient? And we know that in your Viva and in your theory exams, you need to different, and even in your clinical practice, you need to divide the investigations into 3 types. First, investigations to confirm the diagnosis, investigation to stage or grade the disease, or an investigation for treatment. Okay, so don't start writing CBC, LFT, RFT. No, wait. Okay, you first write which investigation will help you diagnose this condition. Okay, and whenever you are writing these investigations, you need not just write the name of the investigation, you have to write how will this investigation help you. Okay, so first investigation, first and foremost, it's an abdominal inguinal swelling. You always start, in it superficial, you always start by doing a ultrasonography. So ultrasonography, abdomen plus pelvis, you'll do. It will help you not only confirm the diagnosis, but also it will help you rule out other conditions like maybe psoas abscess or maybe varicocele, right, and inguinal abscess. So it will help you differentiate with this. But moreover, you will say, sir, hernia is a clinical diagnosis. It is true. It is true. But still, in today's day and age, where you want to be medico-legally safe and where you need to confirm the diagnosis also, okay, and if you want to see that it is not associated with something else, it is always better to investigate. And the first investigation that we would like to do here is ultrasonography and of abdomen and pelvis, obviously including the inguinal region as well. And I'm telling you, another important point in this case is that the patient's age is 75 years. Okay, so if you don't check for his prostate while doing USG, and you don't tell the radiologist to check for pre-void and post-void volume, you are doing a big disservice and committing a big crime in this case, right? Because you know that 75 years, almost, it is said that 80 years of age, 80% of male patients has BEP, okay, benign enlargement of prostate, or BPH, benign prostate hyperplasia, right? So you have to check that. So you have, along with USG A plus P, you are also doing USG prostate volume, pre-void and post-void, and seeing if there is significant post-void urine in this patient. Okay, now when I was a resident, I remember that bedside, when sometimes you don't have USG available at your disposal, you know that you are diagnosed inguinal hernia with the clinical diagnosis, but you still want to see and rule out whether the patient is having prostate. So what options do you have clinically? Okay, you can do a digital rectal examination and you can see the size of the prostate, but another better method is doing a urine flow rate, bedside urine flow rate. So what you do, you drain, make the patient void his urine, put a Foley's, insert maybe 100 ml of urine, 100 ml of NS, and then what will you do? You'll tell the patient to void urine. Okay, and how much time this patient will void that 100 ml of fluid or NS? Okay, you can calculate the urine flow rate. So urine flow rate more than 15 ml per second is normal. Less than 10 ml per second is not normal. This patient is having bladder outlet obstruction. It could be because of anything, maybe BPH, maybe urethral stricture, could be because of anything, and you need to manage it. Okay, so most commonly, if there is urine flow rate less than 10 ml per second, and you did a rectal examination or digital examination, and that is showing an enlarged prostate, it is always better to start the patient on maybe Urimax D, or maybe a tamsulosin with finasteride, okay, whatever combination you like it. Or if it is too enlarged and you think that this patient might require surgery, so take a urologist opinion, and maybe you can couple TURP with the hernia surgery that you are planning, right? So next is urine flow rate. So less than 15 more than 15 ml per minute is normal. Less than 10 ml per bladder outlet obstruction, this is equivocal. You might have to do a proper urine flow rate or uroflowmetry, right? Next up is you sometimes, if you are not sure whether this is inguinal hernia or not, if you are confused between inguinal hernia or femoral hernia, or being there is a inguinal hernia, there is a swelling, but the patient, your sonography is confusing, giving a confusing picture, you might have to even do a CECT, abdopelvis. So that will help you diagnose the condition. Sometimes there is inguinal hernia with femoral hernia. So intraoperatively, if you don't want any surprises, CT scan will also help you diagnose femoral hernia, which is slightly difficult to diagnose on ultrasound. Yes, the next group is investigations to confirm the diagnosis, not to stage the disease. So here you don't have any investigation per se. It is more of used in cancer. So there is no as such investigation to stage the disease. Now coming to investigations for treatment, yeah, here you can write all your routine investigations: CVC, LFT, RFT, PT, and serum electrolytes, ECG, Triple H, and chest X-ray. But here I want to mention two important investigations that you have to do when the patient first comes to you. Okay, though it is not helpful in confirming the diagnosis, but it is very helpful in further management. Here the patient, they have told you that the patient is diabetic for 15 years. Okay, so it is necessary that you get a FBS, fasting blood sugar, postprandial, and even HbA1c at the offset. Okay, because if this is deranged, there are high chances that you might have to postpone the surgery, postpone the primary treatment. Why? Because if you do not manage this sugar levels, manage the sugar levels, get the HbA1c around 6.5 to 7, you will face wound infection and other complications after surgery. The wound won't heal. There are chances of infections. There can be even chances of mesh infection. You need to counsel the patient to get these investigations done and get the sugars under control before actually planning the surgery. Okay, and another important investigation would be to do a 2D echo, because you don't know, 75-year-old, maybe his ejection fraction would have been less than 60, or he would also have a concurrent heart disease, IHD history. It is not given in the question, but there can be. Okay, so you have to do a 2D echo and get that sorted and get a cardiologist opinion go ahead and actually plan the surgery. Okay, also it will help you in management. If the ejection fraction is not much, you might also not be able to give general anesthesia from anesthesia point of view. Okay, so you might have to change the disease, change the treatment protocol, or change the treatment line altogether. You cannot do a laparoscopy in this patient. You might have to do an open inguinal hernia surgery. So all this investigations, though it will help in treating the patient, but it is important to do at the onset. Why? Because the line of management or line of treatment will change. Question: they have asked you describe various surgeries performed for inguinal hernia. They have not asked you what will you do in this patient. Okay, so you have the liberty, you can inguinal hernia. Okay, so let us start. Okay, let us start with initially management of hernia. They used to do it with hernia belt or truss, but it is not used nowadays. So don't advise it, and you can just write a line about it. You don't know, it is not advised nowadays, right? Now coming to the principle of management or what is the common principles of hernia surgery. Okay, so hernia, we know it has content, it has a sac, and it has a defect. Okay, so content, what you need to do, you need to see the content, open the sac, see the content, and reduce it again in the abdominal cavity. If it is irreducible or incarcerated and you have say omentum as a content, you can excise it if it is not going in, but primarily you need to push it in. That is the only thing that you need to do with the content. Second is with the sac. How will you deal with the sac? Sac everywhere, you need to open it, reduce the content, ligate the sac. Okay, and this is true mainly for your indirect hernias. Indirect hernias, you know that we don't need to even open the sac. Direct hernia, it is coming from the deep superficial inguinal. You just push it back and repair the posterior wall, and that's it. In direct hernias, you don't need to do, this is a practical point, more important from PG point of view. In direct hernia, you need not open the sac, you need not perform herniotomy. In indirect hernia, yes, you have to. And whether there is a large defect, say the posterior wall is weakened, you need to strengthen this posterior wall. Okay, so for strengthening the posterior wall, you have two options. Either you can strengthen it with your sutures. So anything you do it with the suture is Herniotomy. And if you reinforce the posterior wall with a mesh, you are using a prosthesis. The suffix you will use is plasty, is hernioplasty. And the first part where we are ligating the sac, opening the sac and ligating it. Opening, what is the suffix you use? You use the suffix of otomy. Okay, so that is herniotomy. Right, so you have what options you have. You can do herniotomy, you can do herniotomy, or you can do hernioplasty, and then you can do laparoscopic surgeries, which we'll be discussing in a while. Okay, so first is herniotomy. When will you do only herniotomy? In children. In children, we know that there is with a preformed sac, that is a patent processus vaginalis. You open the hernia, you open the sac, reduce the content, and ligate the sac. So this is herniotomy, which is done only in children. But you also need to remember that if this hernia, patent processus vaginalis, has fluid in it, this will become congenital hydrocele. If there is intestine coming in it, it will become intestinal abdominal content coming in it, will become congenital hernia. So in congenital hernia, you are doing herniotomy, but even in congenital hydrocele, you are ligating this patent processus vaginalis and you are doing a herniotomy. Okay, so congenital hernia and hydrocele, your treatment, congenital hernia and hydrocele, your treatment would be to do a hernia. So in adults, what options do you have? Say you are doing an open inguinal hernia surgery for this patient. What will you do? You go in, you take an inguinal crease incision, you will deepen it, you reach the external oblique aponeurosis, you see the superficial inguinal ring. Over the superior border of the superficial inguinal ring, you will make an incision, open the EOA, you see the content, you reach the inguinal canal, you lift the cord, and in the cord you see the sac, and this sac can be indirect or direct. Okay, so if it is indirect, you open the sac, that is herniotomy, push the content in, ligate the sac, you have done the herniotomy, and after that, what will you do? You will also see that there is a 75-year-old, I am expecting there will be a defect and the posterior wall will be weakened. So you would do a herniotomy, and we will be discussing herniotomy in detail, different types of it. You repair the posterior wall, and now you want to reinforce it with a mesh. So you take a mesh and post it and suture it, Prolene mesh, non-absorbable mesh, you suture it with the posterior wall, reinforce it, and this is your hernioplasty. So your hernioplasty involves doing herniotomy, doing herniotomy, and even your mesh plasty, right? So this together is known as hernioplasty. So now let us see what are the different types of hernia or rrhaphy that you can do. Though we know that we just use the Bassini's repair, we will be discussing other herniorrhaphies as well. Okay, so the first is Bassini's repair. That is the easiest. We suture the conjoint tendon with the inguinal ligament. We suture it, we approximate it, and your work is done. This is Bassini's herniorrhaphy. The second option you have is the Shouldice repair. What do you do in Shouldice repair is that if this is your posterior wall, that is your fascia transversalis, you separate it from between. You separate it, okay, you separate it from between, and then you overlap both the separated parts one upon the other. So this is what double breasting of fascia transversalis. So just look at here, we are separating cutting the fascia transversalis into two. Okay, you can see that one part and the other part, and then you are overlapping it. You're suturing one with 3 and 2 with 4. So this is known as double breasting. This is your Shouldice repair. The third is Maloney darning procedure. This was a time when the mesh was not available. So what he did is he loosely placed sutures between conjoint tendon and inguinal ligament. You see, multiple sutures are placed between conjoint tendon and inguinal ligament. Okay, and he horizontally and vertically. Are you understanding? So this is dense continuous sutures, and it has formed a mesh kind of thing. Okay, so this is Maloney darning procedure, where an artificial mesh is created by dense continuous sutures between conjoint tendon and inguinal ligament. The fourth one is McVeigh's repair. McVeigh's repair, we need to understand that there is inguinal ligament between the pubic tubercle and ASIs. You have the inguinal ligament. This inguinal ligament turns. Okay, this inguinal ligament turns. This turning is known as the lacunal ligament, and it continues over the pubis, over the pubic bone, and that is known as the iliopectineal ligament of Cooper. So in Bassini's, what we were doing, we are suturing the conjoint tendon with inguinal ligament, the upturned part of inguinal. Conjoint tendon with upturned part of inguinal ligament. What are you doing here? You are suturing the conjoint tendon with this iliopectineal ligament. That's it. You are suturing the approximating the conjoint tendon with iliopectineal ligament of Cooper. Okay, so this is McVeigh's repair. So these are all the herniorrhaphies you have. Right. The fourth, the mesh plasty, we know that it is Lichtenstein tension-free mesh repair. I won't go into the detail. We all know about it. We use a Prolene mesh. You fix it with the Prolene suture as well. And what it does, how does it reinforce? It causes aseptic fibrosis. And what is the qualities of the ideal mesh? You need a low weight mesh, thin fibers, and large pores. Right. So this is all the open inguinal hernia surgeries. Now, let us quickly discuss the laparoscopic hernia surgeries. You have two options. One option is, very easy. It is very easy to understand. In first option, what are you doing? So now you have become a laparoscopic surgeon. You are going in inside the abdominal cavity. Okay, so you take an infraumbilical incision, you put your port inside, you breach the peritoneum, go inside. You are in the abdominal cavity. Okay, through the abdominal cavity, you are now going to the inguinal region. Now I can see there is inguinal region there. Okay, but I need to place a mesh. I cannot put the mesh below the peritoneum. I need to open the peritoneum, so I will open the peritoneum, reflect it, and I have reached the inguinal region. Do the dissection there, reduce the sac, put a mesh there. Okay, so this is the peritoneum. I am putting the mesh there, and above it there is fascia transversalis. So this is, you are repairing the fascia transversalis posteriorly. Hence these laparoscopic hernias repair are also known as posterior repair. Open inguinal hernia, you are putting the mesh anterior to the fascia transversalis. So that was your anterior repair. This is your posterior repair. Okay, so you have reinforced the mesh, and now I will again the reflected peritoneum, I will again suture it. Okay, so this repair is, you are going inside the abdominal cavity, so through the abdominal, inside the trans-abdominal, and then you are again going into the pre-peritoneal plane. So this is trans-abdominal pre-peritoneal repair. The other repair is that you be outside the peritoneum. You don't go breach the peritoneum, you are outside. Okay, so this is total extraperitoneal repair. Okay, totally you are repairing the putting the mesh extraperitoneal. This is total extraperitoneal repair. Technically, this TEP repair seems easy, but it is very difficult to perform. TAPP is easy to do, but it has the disadvantage that you're going inside the abdominal cavity. Obviously, there are chances that you might injure the intestinal contents, right? And when you talk about TEP and TAPP, it would be a crime if you do not mention the triangle of pain and triangle of doom. Okay, so you need to remember that what I am doing, I have reflected in TAPP, I have reflected the peritoneum down. Now this is the anatomy I am seeing at that corner. Just imagine your room, wherever you are sitting. You remember there is a left corner, left inguinal region and right inguinal region. In the right inguinal region, you have lifted up, you have reflected the peritoneum down, and there you are seeing that there is a deep inguinal ring, and through that deep inguinal ring you can see because it's in the fascia transversa, you can see the structures entering. So what is entering? The spermatic cord is entering and the testicular vessels are entering. The spermatic cord is entering and the testicular vessels are entering, and you see the inguinal ligament. The inguinal ligament that you see it from this side of the abdominal cavity, from inside, is known as the iliopubic tract. Okay, so you have iliopubic tract, you have the deep ring, and you have the vas deferens. Okay, so vas deferens and testicular vessels are entering, and this is the iliopubic tract. Okay, so medially you have this triangle which is made by the vas deferens, the testicular vessels, and the peritoneal reflection. Okay, this triangle houses the external artery, external iliac artery, external iliac vein, and the genital branch of genitofemoral nerve. So if you put a tacker here, while for suturing the mesh, if you put a tacker here, you will injure the vessels, and obviously there will be a lot of bleeding and you will be doomed. So this is known as triangle of doom. And this triangle, which is made by testicular vessels here, iliopubic tract here, and the reflection of the peritoneum, there you have three nerves, that is lateral cutaneous nerve of thigh, femoral branch of genitofemoral nerve, and the femoral nerve. These are the three nerves which are present. If you put a tacker here, the patient will complain of pain, a lot of pain, because the nerve is getting impinged, and this is known as triangle of pain because it is causing so much of pain, right? So these are the two triangles, triangle of pain and triangle of doom. Together, these two triangles is known as trapezoid of disaster. So the last part I want to discuss here is the circle of death. Here, if you see, there is inferior epigastric artery, and here you have the obturator artery. Inferior epigastric artery is the branch of external iliac artery. The obturator artery is a branch of internal iliac artery. Through the inferior epigastric artery, there is a aberrant obturator artery which is going to the obturator artery. Okay, and this lies just behind the pubic tubercle. If this is injured during the surgery, or if you put a tacker there, it will bleed torrentially and it can cause death. So it is known as circle of death or corona mortis because it is forming a circle. You can just see here, this is the external iliac artery which we spoke about, and it's a branch which is known as the inferior epigastric artery. Here you have the internal iliac artery. This is giving a branch which is the obturator artery, and there is a aberrant obturator artery which is coming here. If this is injured, it can lead to again torrential bleeding, and this would lead to death, and hence it is known as the corona mortis or circle. Thank you so much. I hope you have understood this concept and the approach to write the question. Subscribe to my channel because I post video weekly, and share it with your friends as well. See you again in the next video.